Chapel and Cox and Graziano Funeral Homes. Jennifer is here to discuss a sensitive subject we all need to talk and think about. Here now is Jennifer Graziano and Time to Talk.
Good morning, Westchester. It's 9 a.m. on Monday, and that means it's time to talk to me, Jen Graziano. I'm a licensed funeral director who oversees my family's funeral homes, Cox and Graziano of both Mamaroneck and Greenwich, and the Zion Memorial Chapel of Westchester. Every week I come to you discussing important topics and sensitive matters that all of us need to pause and reflect upon at some point. And through this show, I hope to provide a platform to do so. If you're joining us on air this morning on 1460 WVOX, we'll take questions, comments, and calls to 914-636-0110. And good morning to the guys in the control room. Sorry, my back is to you today. Good morning, Facebook Live viewers. Thank you so much for joining. Tim is behind the camera here. We'll always take your comments here as well. So I am joined by a very special guest this morning, and I'm excited for the information he's going to share with you. He is a geriatrician, a geriatric medical practitioner, a doctor who specializes in the aging population. And I think that is so important because I do believe there's a different requisite of care, a different approach to care as we get older. And I think it's important to be matched up with the best people who can help you. So Dr. Paul Cavaluzzi is a geriatrician practicing in Westchester, centrally located in White Plains, also seeing patients in Rockland and Putnam counties. And good morning, doctor. You're on the line. Dr. Cavaluzzi, do I have you on the line?
Yes, I'm here.
Hi, good morning. Thank you for joining us.
Not a problem. Thank you for having me on. I appreciate it.
So my connection to you and how I met you actually was through my line of work, and I was very struck by your affinity for your patients, your desire to help, and you really went the extra mile. Full disclosure, we had a death certificate issue, and you really, I had not seen a physician similar to you who had such an interest in helping the patient and taking care of the patient, and we got to chatting a little bit, and I thought you'd be a great fit for the show. So here you are, and I'll have you tell the audience a bit about yourself and the area of medicine that is your specialty.
Well, first of all, thank you for those kind words. Geriatric medicine or geriatricians are physicians who go on for extra training to learn about how to care for seniors. So after going to medical school and then going on to do a residency in either internal medicine or family medicine, doctors that want to become geriatricians then go on to do a fellowship in geriatric medicine. And then there's a separate board that they have to sit for after that to become a board-certified geriatrician. And during their fellowship, they focus on just providing care for the seniors and all that involves. Insofar as my practice, what we do is we provide home visits and also assisted living visits too for seniors. There's, as you probably know, for a lot of the seniors, it's challenging for them to get out of the house. Mm-hmm. We are able to go into the home, and we're able to do geriatric evaluations there in the home for them. Sometimes family members have some, or the people themselves might have some questions about their care. It's not uncommon to have. It's not uncommon for the seniors to have multiple different diagnoses that's impacting their overall health, and sometimes they just want to know how best to proceed. So I'm able to go into the home and do a geriatric evaluation for them and sometimes help guide them. Whether or not they're having troubles with falls, let's say, or maybe there are some cognitive issues that either they themselves or family members are noticing that they want an opinion on. Medications is also something that geriatricians look at. It's not uncommon to find seniors on multiple medications, which sometimes can be interacting in a dangerous way for the person. So we're able to do that in the home for them.
So it's certainly a heightened specialty. You know, when in the beginning of life, we have pediatricians that tend to the needs of a child. You're not bringing your child to a general practitioner. You're bringing your infant, your newborn, and your young child to someone who specializes in that, in that patient. So this is the other end of the spectrum, but the same heightened need. And, probably this goes a little unnoticed, I would have to imagine, that people have a primary care physician that they might remain with through their aging years and who, would provide wonderful care. But there are specialties that you're addressing. You're looking at the patient as a whole. You're looking at, their medication list as a whole. You're understanding the body works as a cohesive unit. So a pill you're taking for ailment A is going to have impact B. So you're looking at all of this. Again, the cognitive evaluations, fall risks, these are just taking their care one step further. Do you find that there's been more awareness of geriatric medicine in recent years, or do you find the opposite effect, that people are just sticking to what they know and not making the pivot to you as they come of age?
A little bit of a mixed picture. There are certainly people out there, and I think you bring up a good point there, where when we're younger, our parents bring us to pediatricians, and then we transition after that. After a certain age, we transition to a primary care provider, and then as we get older, yes, there are geriatricians, but there are a lot of people that actually don't know what geriatric medicine is, and I've come across that a fair amount, where they've heard of it, but they aren't really quite sure what geriatricians do. Mm-hmm. So I have seen some of that. But then certainly I've also met a fair amount of people that are aware of what geriatricians do and the value that they bring, and again have asked for evaluations.
So when in geriatric care, is the goal quality of life, or is it aggressive treatment of an illness, or is it more just to sustain life, enhance the quality of that life? How would you describe it? Is it an aggressive model of medicine and care?
Well, you see, it's different for everybody, and that's an excellent question, because that really, to a certain extent, is at the heart of it. What are the goals of care for that particular person? And it's not just how best to manage, let's say, their high blood pressure or their diabetes. It's how best to manage their high blood pressure in conjunction with their diabetes, maybe in conjunction with their dementia, and in conjunction with their bad spinal stenosis, and that's not an uncommon scenario there. Or how best to manage all of those diagnoses. You have to look at what the life expectancy is. Do they have any chronic illnesses that would change how aggressive we are in managing some of their illnesses? So if somebody, let's say, has advanced dementia and their life expectancy as a result of that is not 10 years or so, we're going to be less aggressive, and we're very likely not going to be screening people, let's say, to prevent cancers or catch cancers, to use that as an example. Again, we had mentioned this briefly before about doing fall risk assessments. In our diabetics and our people with high blood pressure, too, that are on multiple medications, you have to be careful. The goals for an older diabetic oftentimes are not the same as the goals for a younger diabetic, because you don't want to precipitate a fall, which can happen if you get a little too aggressive with the diabetic management or with the management of the blood pressure. So there's no one answer, and that's
right.
Part of that's part of what an evaluation is to sit down and have a geriatrician sort of look at everything and look at the whole picture, and then also talk to the person too, and say, what is it that you want?
Yeah,
you still want, you have, 5, 6, 7 different diagnoses here. You're on maybe 5 to 10 different medications. You've been in the hospital 3 times already in the past year, maybe. What is it that you want for yourself? Do you want to continue to keep going to the hospital? Unfortunately, sometimes with some chronic illnesses, there isn't really anything that we can do to cure that. So that's a conversation that the geriatrician has to have with that person, and ideally with the healthcare proxy or the caregivers there too, the family members. How best do you want to proceed? Do you still want to go to the hospital? Do you just want to not do that and focus more so on your quality of life? Or are we going to be super aggressive at managing some of these other illnesses, or are we going to focus more on quality? So there's really no one answer, and it's individualized based upon, in part, what the person's wishes are.
Absolutely. And there's some underlying philosophical questions here that come to surface in terms of quality of life, quantity of years versus quality of them, and the transition to a more palliative model, which we'll get to in a moment. But I want to discuss, you mentioned healthcare proxies. So oftentimes, if you're dealing with an advanced age senior, there's either a healthcare proxy or there are caregivers, adult children, most likely. How do you navigate that? First of all, from a HIPAA perspective of sharing health and medical information, when you have such a vulnerable patient that is being brought to a doctor most likely, or has somebody in the room with them while you're there, how do you navigate privacy regulations? How do you share information with family members or bring everyone to the table for a conversation?
So a healthcare proxy, and this is an important point, a healthcare proxy really is something that we all should have, because something unfortunately can happen to any of us at any stage, not just the seniors. But a healthcare proxy, for the listeners that aren't aware, is an individual that we assign to make our healthcare decisions in the event that we can't. So if something happens to us and we're unconscious and in the hospital, and not able to make our own decisions, the healthcare proxy would help make those decisions for us. So it's important to pick somebody that A, you trust, and B, that understands what your wishes would be in certain situations, because the doctors are going to come to them and say, okay, we have to make a decision about this, that, what is it that your loved one would want? And ideally, the healthcare proxy should be making these decisions based on what the person would want for themselves. So it really is an important, and it's super simple to do. You can go on the New York State DOH website, and you can, if you look up healthcare proxy, there's a form there. You can download it, and you can just fill it out, assigning the person that you want to make your decisions, and then you can also put a backup person there too. In the event that first person isn't available for some reason. So it's something that I definitely recommend that everybody have. And that's something that, again, part of sort of an overall comprehensive evaluation is looking at things like that. It's looking at things, what we refer to as advanced directives. And do you have a healthcare proxy? And if not, let's put one in place. Who do you want to make your healthcare decisions? And, oftentimes when I do an evaluation, family members are involved and family members are there. So the patient is okay with that. Okay. But in situations sometimes maybe where it's just me and the patient, I'll just ask them, because if they still have the capacity to make these decisions, I ask them and say, is it okay maybe if we, bring your family involved? Who would you want to be your healthcare proxy? And maybe they'd say, my son or my daughter or my husband or my wife. You say, okay, so is it okay if we sort of bring them in on this, and because they need to know what your wishes are. And then we get them involved, and we not only work to have them assign a healthcare proxy, but again, also it's important for the proxy to know what the wishes of that particular person would be.
Dr. Cavaluzzi, today most medical models are merger and acquisition, larger medical service providers taking over, groups growing very large, and as a result, they're forced to reach a certain quota of patients, which means that each patient is getting less time. These are insurance company mandates, and again, the larger parent companies now that buy up the smaller medical offices. So it changes the dynamic of care. And oftentimes, when you go into a doctor's office, you always leave and, remember the question you wanted to ask your doctor. So I have to imagine that your model is also allowing for extended visits, more thoughtful and comprehensive visits, and really taking the time to address the gamut of issues that can affect the seniors, correct?
Well, being in the home does afford you some things. You have an opportunity to see somebody in their own environment, which sometimes is very helpful, because you get certain clues, how does the home look? Is the home well kept?
Right.
Is it not? I mean, sometimes that can be a fall risk if there's just lots of clutter there. But you get some insight into how well someone's taking care of themselves.
Sure.
And sometimes with our cognitively impaired population, they may appear intact, but we have an opportunity to view them in their own environment. You get a different insight. So that's one advantage to doing a home visit. But in this practice, yes, I do have some extra time that I can sit there with them and go over what oftentimes is 80 years of medical history and 80 years of there's usually a lot to go over. And it's unfortunate, and you make a very good point, it's unfortunate that the healthcare system doesn't necessarily value that or always give the docs an opportunity to really do some of this and take the time that's required.
So anyone just joining us, I'm on the line with Dr. Paul Cavaluzzi, a geriatrician practicing in Westchester County, serving patients in the surrounding communities as well. And we're discussing the unique niche of geriatric medicine and the different approach to medicine involving home care visits, comprehensive visits where the doctor is really evaluating the psychological, emotional, and physical aspects of a patient, because obviously all three unite to paint a picture of health. Dr. Cavaluzzi, what is often is there often a transition from you to palliative care, or is that a level of care that you're also able to provide? And perhaps go through the distinction between medical care and palliative care.
Yep, another excellent question. So palliative care physicians, if you will, these are docs that go on and do a hospice and palliative care fellowship. And now palliative care, and what I tend to see is people get the terms palliative care and hospice care confused.
Correct. Yes.
Yeah, and you see that too. I'm sure there's some confusion there. And so palliative care, you don't necessarily have to be at the end of life to qualify for palliative care. Palliative care is care that we provide somebody that has a chronic illness that gives them. So somebody that has a chronic condition that maybe gives them chronic pain, let's say. A palliative care physician might be able to help with that. You're kind of helping to palliate some of the symptoms of the chronic illness that they might have. You don't necessarily need to be at the end of life to qualify for a palliative care evaluation. So there are times in my practice where I will work with a palliative care specialist to help come up with a comprehensive plan for whatever that chronic illness might be, whatever those symptoms that might need some palliation. So that's what palliative care is. And hospice care is end-of-life care. Mm-hmm. Hospice care is it's an insurance benefit on our Medicare that we get where you need a physician to say with a degree of certainty that, in their opinion, in their medical judgment, that a person has about 6 months or less left to live, okay? And if that's the opinion of the attending physician plus the hospice medical director, then they can get put onto a hospice program. And hospice programs there are hospice groups out there that actually can be provided in the home. A lot of people have hospice care provided in the home until they pass. So if somebody has end-stage COPD or end-stage congestive heart failure or end-stage dementia, they can get put on hospice care. And then that hospice group will come in, and there's a hospice nurse that's available. There's a hospice physician, also a hospice palliative care physician that's involved in the care. And there's other types of support services that are available for not just the patient to ensure that their remaining months are made as comfortable as possible, but there's also lots of support services for the family members too.
Correct.
So that's the difference between hospice care, which is more geared towards end of life, and palliative care, where a person really just has to have some chronic conditions or symptoms, if you will, that need palliation, but you don't necessarily need to be at the end of life.
You know, there have been studies done that show that palliative care can often, you know, not extend life by much, but extend life in the sense that if a person maybe had, 8 weeks to live, that you know, they would add on 3 or 4 because there was a quality of life given. And hospice, too, has been known to do that. You know, the book that we discussed that we were emailing about, there were case studies in there that when the medications were removed, family members were able to have more lucid, meaningful conversations. There were things that got to be said between families in the end that perhaps might not have been if they were clouded and impaired by judgment through medication. So there are many benefits, but they're both very hard words to hear. You know, people at the H word, I've always thought in my lifetime as a funeral director, and even personally myself, the very, very brief period that my mom had hospice care, you hear that word and your heart stops. It does. But I think education is certainly important as well, especially on the palliative care side too, because there are ways to make the end better. You know, the end is inevitable for all of us, but there are ways to make it a better end. I'm sure you'd agree with that.
Absolutely, yes. And that actually, what you said actually goes back to about the medications, actually goes back to something that we mentioned earlier about, you know, part of what a comprehensive evaluation is part of a comprehensive geriatric evaluation is looking at the medications also. And I've definitely seen situations where I've come into the situation and the person, like you just said, they're not really communicating clearly, and that can be for different reasons. And and sometimes, you know, it's nobody. We give our best judgment, but sometimes we're not 100% sure. We kind of have to see how things go. And sometimes when you back off on medications, people do, in fact, wake up. It was some of the medications that maybe were making them that way. So that's why it is important to take a comprehensive look at the medications and see whether or not, if that's responsible for some of the symptoms that we're seeing. Definitely.
Sometimes it's just too much. I mean, there's no other word for it. And then also, you know, when you have seniors living independently who have the pills, you know, segregated by days and they're not taking one versus the other. So that's such an important part of what you're doing. And I really think you're doing a wonderful job of outlining why geriatric care is so important. So, you know, carrying on with the general practitioner, again, you're going to be subject to the shorter visits. And yes, they might know you for years and years and years, but your needs evolved. And there is that psychological and emotional component now that does affect your health. Seniors living in isolation over COVID, that isolation undoubtedly yielded harmful physical effects. I'm sure you've seen a ton of that in your practice.
We did. It was really sad, actually. The isolation and having their mobility restricted too, and so maybe they were out and about, but now because of the quarantine and we saw psychological changes, we saw a lot of depression, increased confusion that we saw as a result of the isolation. And then also saw as a result of the decreased opportunity that they had to get out and walk around, we saw weakness and some falls and people that weren't falling prior. Some people, you know, broke bones. And that was a very difficult thing for all of us to have to watch. And I should just mention one thing, just to back up a second. You know, you had mentioned about somebody working with their primary care physician. They don't necessarily have to sever that relationship. That's not necessarily, you know, they can still have a geriatric evaluation done and still maintain their relationship with their primary care provider if, in fact, that's what they choose to do, because, like you mentioned earlier, oftentimes they do have a long-standing relationship with them. So there were situations where I worked with can go in and do an evaluation and work in conjunction with that primary care provider. So.
Wonderful to know. Dr. Cavaluzzi, how can our listeners and viewers reach you to schedule an appointment or a consultation?
So what they could do is they can call the office. That's 914-505-6142. And they can just speak with the office manager and let them know that they're interested in obtaining a geriatric evaluation. And then my office manager will just walk them through the steps.
So once again, that's 914-505-6142, Geriatric Medical Associates. And actually the website is geriatricmedicalassociates.com. As I mentioned when the show began, I can attest to you take this work very personally, Dr. Cavaluzzi. You had a patient who passed away, and you really tried desperately, to keep her having a quality to her life to the very end. And even after her passing, your care continued for her. So I'm sure you get bonded to people, and I'm sure you really are taking the time to get to know each person individually and their situation.
Well, thank you, Jen. I do appreciate that. And thank you for the work that you do, too. It's very important, raising awareness and having these conversations. It's important stuff. So thank you.
You're very welcome. And thank you for recognizing. So once again, Dr. Paul Cavaluzzi, Geriatric Medical Associates, centrally located in Westchester, but will visit patients Rockland, Putnam, 914-505-6142. Keep up the great work, doctor, and have a great day.
Thank you, Jennifer. You too.
Thank you. And this is Jen Graziano thanking you for taking the time to listen as we took the time to talk. Have a great day, Westchester. Bye-bye.